Welcome everybody to this second interim update webinar from the 21st International Workshop on HIV drug resistance and treatment strategies. I'm Dr. Dan Kuritzkes at Brigham and Women's Hospital and Harvard Medical School in Boston, and I'm delighted to welcome you to what's going to be a really fascinating program today, whether it's afternoon, evening, or early morning for you. We have a number of very nice presentations and cases from around the world, including speakers from Vietnam, from Thailand, from Cambodia, and from South Africa and Uganda. Without further ado, I'm going to go ahead and introduce Dr. Elliot Raizes from the United States Center for Disease Control. Dr. Raizes is one of the members of the organizing committee for the International HIV Drug Resistance Workshop. He's the branch chief for HIV Care and Treatment Branch and part of the Global HIV/TB Division and Global Health Center at the CDC, and he will make some introductory remarks. So Elliot, over to you.
Thanks, Dan. And hi, everyone. Thanks for joining. I'm just going to give some brief introductory remarks before we get to the main events, which are our four speakers from the other countries. So I think most of you are aware that around CROI for this year, early this year, WHO released a report suggesting that there was increase in HIV drug resistance to dolutegravir, and this certainly created concern in the global HIV provider community. The data for this report was primarily based on 4 studies that CDC helped support in Malawi, Mozambique, Uganda, and Ukraine. And what you can see here is that we did see a range of drug resistance, dolutegravir drug resistance mutations from 4.4 to as high as 20.8 across these 4 studies. The populations that were tested in these studies, what they did have in common is that they had elevated viral loads on TLD regimens, but there were other ways in which these populations were selected, suggesting that these were not similar populations. But nonetheless, this was the range. And the reason that WHO said there was an increase was because prior to that, when they did an analysis of clinical trials, the range was found to be anywhere from 0.1% to 3.4%, so suggesting that in real world, dolutegravir resistance may be increased compared to clinical trials. Before anyone panics about this, though, I think it's important to provide some perspective. This is based on an analysis that Juliana De Silva reported at AIDS in Montreal in 2022 that showed how our viral suppression was increasing with the incorporation of TLD into PEPFAR programs. And so what I'm showing here is just based on an assumption of 8% of people failing with dolutegravir resistance compared to the 80% that we would typically see failing with NNRTA resistance on TLE regimens. You can see that there's still almost a 20-fold decrease in the prevalence of resistance among people with ARV exposure when that ARV is TLD. So TLD continues to be a very effective drug. And so because of that, and because there is no global guidance on management of PWH with virologic failure on TLD, PEPFAR decided to go ahead and put out a note to the field in July of 2024 that were our sort of considerations for management of patients with non-viral suppression on dolutegravir-based regimens. And so basically, I'm just going to go through those considerations just to make you aware of that. We continue to support dolutegravir-based regimens, both for adults and children. And also we also wanted to acknowledge in these considerations that dolutegravir resistance can occur when there is virologic failure, oftentimes which was defined as a second non-suppressed viral load within at least 9 months of dolutegravir exposure. However, we also felt that because dolutegravir resistance remained quite uncommon, the vast majority of people would not benefit from a switch to a PI-based regimen. We also mentioned that the management strategy at this point would be adherence counseling, and adherence interventions have been shown to be effective in terms of allowing people to resuppress when their viral load is elevated on dolutegravir regimens, as seen from this data from 3 countries. And so keeping this in mind, we felt that still the vast majority of people with dolutegravir elevated viral loads and dolutegravir exposure would not have dolutegravir resistance. And so we should continue to provide psychosocial support for that group that's noted in yellow here. We did also start talking about the consideration for drug resistance testing, and you'll hear about drug resistance testing in the presentations today. And then finally, we also talked about what might be some of the risk factors for dolutegravir resistance that could predict, that could allow us to predict who would benefit from a drug resistance test or who might benefit from an empiric switch to protease inhibitor-based regimens. So these are all things that we wanted to consider in the PEPFAR work. And so our next steps, we anticipate updated WHO guidance on this issue. We will have a formal PEPFAR technical guidance beyond the note to the field. We continue to review country guidelines, and today is an example of this for all of us. We continue to do HIV drug resistance surveillance, and as Dan noted in the advertisement earlier, there will be further discussion on these topics, and we encourage all of you who are interested to try to attend our meeting in April of next year in Cape Town, South Africa. So with that, I'm going to turn it back over to Dan for the next speaker. Thanks.
Thanks so much, Elliot. So our next speakers are going to be Dr. Nhan, who is the HIV treatment head from the Vietnam Authority for HIV/AIDS Control, and Dr. Trieu Ly from the Tropical Disease Hospital in Ho Chi Minh City. Dr. Nhan graduated as a general practitioner from Hanoi Medical University and has played an important role in helping to manage infectious diseases in Vietnam. He has been implementing the transfer of ARVs from international aid to health insurance in that country and has participated in strengthening the capacity of health facilities. Dr. Ly is a senior lecturer in the Department of Infectious Diseases at the University of Medicine and Pharmacy in Ho Chi Minh City in Vietnam, and is also the head of the clinical trial unit for tropical medicine research at the Center for Thalassemia in Vietnam. And it's my pleasure to have them both present cases from Vietnam in this program now. So over to you.
Okay, thank you so much. Thank you so much, Dr. Dan. Can you hear me?
Yes, we can.
Okay. I'm so sorry because I am on the Cambodia travel, so the network have a broken. So that's why I'm using the data from the cell phone. But I'm so sorry if you cannot hear me well. So yeah, good evening, everybody. Because in my country in Cambodia is 11 p.m. Therefore, I think I can attend. I will attend this meeting with the webinar with in the 30 and 24 minutes. So my presentation, my talking now, I would like to talk today with you about the HIV drug resistance in Vietnam. So here, this slide talking about some about HIV profile in Vietnam. Up to now, so the total people living in Vietnam is 250,000 people living with us, and we started ARV from the 2000, and up to now we have over 180 nearly 89,000 people on HIV. And we also do providing about the viral testing, and by the end of the last year, the COVID viral testing in the Vietnam is about 80%, and the prevalence of the people in US with the suppression value is 89.4%. There are some the there are some the the chain related to the new HIV infection in Vietnam. You can see that the most people in Vietnam now is the MSM with the, the KP about the 58% people in West East was MSM, and the sexual transmission is a major way for HIV transmission in Vietnam. And in Vietnam, we did transition to ARV service to social health to 10 years ago. So there's some of the factor impact to ARV in my country, because we got some the delay related to the procurement progress, and the Mason was facing to change their arrangement because of lack of ARV in some time. For ARV arrangement, the first line Vietnam is a dolutegravir for 5 years ago. This is a national guideline, and we can see that for both adult or adolescent and other children, they are receiving the dolutegravir in the ARV children, ARV regimen. And this is like talking about the number of the ARV regimen with the dolutegravir. And we started that in 2020 with a very, very few patients receive a TLD. And we also phasing out the TLD 600, and also expansion of using of DTG. For the adult, we started at 2019 at very, very few patients, 99% only. But the number, and for the children, we started providing, we start providing the DTG, dolutegravir for the children, and by the end of the 2022, 2 years ago. And look at this slide, you can see that the number of the patients receive dolutegravir are increasing. And by the last year, we have 82% of patients on TLD in Vietnam, amount to the 20, with a total to 46,000 people on TLD. And regarding about the HIV drug resistance in the Vietnam, we started implement the HIV drug resistance in Vietnam in 2020 with the component of EWI and TLD, TDR and PDR and the ADR2. And in Vietnam, we have 2 lab. I can do the HIV drug resistance to meet that meets the WHO standard. And for ADR and PDR, you can see that the prevalence of ADR and ADR is still very high, very low in the Vietnam. Therefore, we in our plan, we have planned to do the TDR and ADR routinely the 3 years. And this slide we have we did the PDR in 2007 and 2020, and to the PDR and ADR very low, less than the 5%. We can also have planned to do ADR with in last year and this year, but up to now we receive a lot of the problem related to beating for testing for HIV/DR. Therefore, the plan to do the TDR and to do the HIV drug resistance for ADR and PDR have not been implemented in Vietnam as planned. And therefore, the plan for HIV/DR in plan, this will be due this year, but because there's something the problem related to bleeding, we have to move the next year, 2020, the next year. And we have planned to providing HIV/DR focus about the TLD for the dolutegravir, and for both adult and also for children too. we want to using the lab-based method according follow the WHO protocol. And however, we also, when we look at about the feasibility of the lab-based in the Vietnam, in my country, we found that there are some problem and challenge related to that. The first about the lab-based method is a very new monitoring approach for HIV/AIDS surveillance of HIV/AIDS in Vietnam now. We have to collect the data with a sample from about the 55 lab value in my countries, and we also in order to do the lab to do the value testing for HIV/AIDS, we also up to now we still have some the difficulties related to procurement of the HIV vaccination testing supply and also bidding processing too. That is why up to now we still, I'm not sure about we can do the HIV/AIDS is next year or not. And if we successful in the bidding and procurement of the testing supply, so we will focus about the ADR and PDR for the DTG, especially for the TLD patient especially about Udan and relation on the TLD in Vietnam. This is some of the very few information related to HIV/AIDS in Vietnam. I want to share with you about that. And we also, Dr. Lee from the Vietnam, he will share with you about some of the case patient on TLD, but we think that we will treatment failure, and we will consider about to do the HIV/AIDS treatment for this patient. And Dr. Lee, please talking about our presentation. Thank you.
Thanks very much, Dr. Nhan. Dr. Lee, please go ahead.
Good morning, good afternoon, evening, everyone. So I'm Dr. Lee from Ho Chi Minh City, Vietnam. So it's my pleasure to be here. So according to Dr. Nhan's opinion, I will show you a case of virological failure in Vietnam. So this is a female patient, 40 years old. She is living in Ho Chi Minh City. Some information related to past medical history. She was diagnosed with HIV infection in 2018 during pregnancy, and she thought it was related to sexual transmission from her partner. Her CD4 count at the time of diagnosis was 187. No history of opportunistic infections, happy and Hep C negative, and HIV stage 1 according to WHO classification at the time of diagnosis. No other medical issues or no regular medications and no allergies in this patient. About her social history, she is a factory worker and she has no intravenous drug use. And right now she's single. About her child, it is HIV negative after birth. There are some important points related to this case. In 2018, she was first diagnosed with HIV during her pregnancy at another facility. And of course, at that time, she was asymptomatic. She had normal weight 54 kilogram, normal laboratory bloods including hemoglobin, renal, and liver profile. Her CD4 count was 187 cells. So at that time, she was transferred to STD hospital for tropical diseases at outpatient clinic, and she remains well and asymptomatic. So at that time, she commenced on tenofovir, lamivudine, and efavirenz. After 6 months, she would check viral load, and it was undetectable with under 220 copies per ml. And CD4 count was positive with a 400, more than 400 cells, and her clinical performance was good. Increased weight by 6 kilogram, and normal lab bloods were good, and she has good tolerance with that regime, and she continued the same regime. And from October 2019 to October 2020, she has good performance and had good adherence to this regime. But however, in October 2020, she was transferred to TOD due to a national guideline supply issue with evidence. So at that time, we transferred to this regime. And at that time, her CD4 count is very good, and her viral load is good too. In October 2021, her clinical performance was stable, and her investigations are good. CD4 count is more than 300, and her viral load is good and detectable. She has good tolerance to TLD. And in the COVID-19 pandemic, she also took this regime regularly and had good adherence. But at the beginning of this year, 2024, she still remains asymptomatic, but her active viral load is high, more than about 50,000 copies per ml, and CD4 count is not available. She continues to TLD and she reports good adherence. So we continue that regime, and after 6 months, we repeat her viral load, and also we also explain her and focus on her adherence, and she makes sure that, and she has good recognition about the importance of adherence to ART. But in the August 2024, she remains asymptomatic, but her viral load is positive, more than 200,000 copies. So we consulted with our colleagues in a hospital and decided to switch to the second line ART with zidovudine, lamivudine, and lopinavir in line with national guidelines for ART failure. So this is some data in this case. A 40-year-old female, previous fit and well, and she has diagnosed with HIV 6 years ago, and WHO stage 1 according to WHO classification, and she's still asymptomatic during her treatment, and she had good adherence to ART since diagnosis with no symptoms. About ART history, tenofovir lamivudine evidence from October 2018 to October 2020, and at that time she was transferred to tenofovir lamivudine and dolutegravir according to the national guideline. About treatment failure in January 2024, the active viral load is undetectable, and after that it increased to 50,000, and after 6 months we check it increased 200,000 copies per ml, and at that time we switched to second line therapy at the August 2024 with zidovudine, lamivudine, and lopinavir booster. Because right now in Ho Chi Minh City, active during time is not available, so we do not run that testing in this patient. So on the latest follow-up, she has some complaints related to dizziness and fatigue since starting second line agent. So I would like to give some challenges of managing ART failure in Vietnam. The first one is limited access to active genotyping to attack drug resistance. As Dr. Nhan have just mentioned, right now genotyping is currently unavailable at most institutions in Vietnam, and therefore it is very difficult for clinicians to distinguish between true virological failure and adherence issues. Second thing is that unknown prevalence of drug system mutations in Vietnam. So population-based studies profile HIV drug resistance are limited in Vietnam at that time. So it is difficult for clinicians to predict likely mutations to guide second line or third line regime joints. And finally, limited availability of the second and third line ART due to supply issues and high expense. Another thing is that some second line, third line agents may be poorly tolerated, but there are no other options available in Vietnam, which impacts adherence and quality of life for our patients. So there are some future considerations for policy research. Firstly, I think widespread access to HIV genotyping surveys in Vietnam for patients experiencing treatment failure. The second is improved availability of range of second and third line ART options. The third is more affordable HIV viral testing to facilitate close monitoring and fast detection of ART failure. The fourth, genotyping for profiling studies to understand prevalence and importance of HIV drug resistance in Vietnam is very necessary for most of the clinicians in our country. And the last one, I think investigations of reasons for treatment failure in Vietnam. Non-adherence versus biological failure is the most important thing to transfer other second and third line regimen in our country. Thank you very much for your attention.
Thank you so much, Dr. Lee, and I'm glad to see that there are many questions coming in through the Q&A widget. We'll be collecting those, and those will help to guide our Q&A session at the end of the presentation. So let me move quickly now to introduce the next speaker. It's really a great pleasure for me to introduce Dr. Opass Putcharoen. Dr. Putcharoen is the director of the Emerging Infectious Disease Clinical Center at the Thai Red Cross in Bangkok, and also chief of the Division of Infectious Diseases at the King Chulalongkorn Memorial Hospital. He serves as a WHO consultant on advanced HIV disease, as well as an expert on Mpox. And I'm really very proud to say that he also spent several years as a postdoctoral fellow in my laboratory. So it's great to see his current success. So Opass, without any delay, over to you.
You just need to unmute Dr. Opass.
Yeah, we can see your slides, but can't hear you yet.
Yeah, thank you, Dan. Thank
Perfect.
you for your kind introduction, and glad to be here to speak to you about the case from Thailand. Before moving to the case, I would like to mention a little bit on our Thai HIV guidelines. So in our guideline, we have implemented dolutegravir in our first line regimen since 2021. This is the guideline. We usually provide OI screening and STI screening before ART initiations. And in our Thai guideline, the baseline HIV viral load and drug resistance testing before ART initiation is not recommended before because we don't have much money to spend on this. For the first line regimens, we now recommend dolutegravir as a first line. It should be used in combination with TDF or TAF plus TTC or FTC in single tablet regimens. The most popular regimen in my country is TLD, followed by TAF, FTC, dolutegravir. For the alternative regimen, we have efavirenz and we have rilpivirine for the third agents, and these agents can be used in combination with TAF, FTC, or TDF, FTC. However, we still have the other options for treatment-naive patients. We also have dolutegravir plus lamivudine as alternative regimens in patients with renal insufficiency and cannot tolerate TDF or TAF. This is a version of 2021 and 22 HIV Thai guidelines. Now we are preparing our new versions, which we will launch in the next year. We are preparing our countries for long-acting injectable cabotegravir and rilpivirine for HIV treatments, and we gonna have cabotegravir long-acting for prevention as well. This is our approach in biological failure. For patient with treatment failure, if the viral load is greater than 1,000 copies per ml, we usually repeat the viral load again to confirm virologic failure. If the level is greater than 1,000, if the patient has poor adherence, we usually send for adherence counseling and repeat the viral load again. If the adherence is now okay and the viral load testing review the viral load level greater than 1,000 copies per ml, the sample should be further sent to the lab for genotypic resistant testing. In our countries, viral load testing and genotypic resistant testing can be reimbursed through National HIV/AIDS program. After we receive the result from genotypic resistant testing, the next regimen will be guided by the results of genotypic resistant testing. If we could detect NRTI RAMs, we're going to change the backbone according to the results. And if we could detect INSTI-RAM, for example, major dolutegravir resistant associated mutation, we're going to change from dolutegravir to PI. So this is the table that show the outline and recommendation for the second regimen after 2 NRTI plus dolutegravir failure. It could be 2 active NRTI plus dolutegravir, or boosted PI plus dolutegravir, or 2 active NRTI plus boosted PI. Let's move on to the case. This case is very short. This is 41 years old man with unsuppressed viral load after ART initiations. This is Thai male patient. He is treatment naive. His baseline CD4 before ART initiation was 256 cells per ml, or 18%. His baseline viral load was 120,000 copies per ml, and his baseline hepatitis B, C, and syphilis serology were negative. His liver and kidney function were normal. So at the time in 2021, we have TDF-FTC furans or TDF lamivudine dolutegravir as a first line, but his physician decided to use TDF-FTC furans for this patient, and this regimen was started, and then the regimen was switched to TLD after 2 weeks because the patient was having CNS side effects. And then the viral load was repeated again at the 6 months after ART initiation. And the result of viral load at 6 months after ART initiation was 1,000 copies per ml, above 1,000 copies per ml. And the patient report a poor adherence to ART regimens. So we send the patient for adherence counseling, and we repeat the viral load again at 1 month after adherence counseling. And the viral load testing showed the virus level was 400,000 copies per ml, and his CD4 decreased from 200 to 33 cells per ml, or 6%. In our countries, if the patient has virologic failure and the viral load is greater than 1,000 copies per ml, we can send the sample for genotypic resistant testing. And this is the results of genotypic resistant testing of these patients. His viral plate is CRF01AE. And for NRTI resistant mutation, we can detect K65R that confer resistance to tenofovir, and we can see M84V with confer resistance to lamivudine, and we unexpected to see Y115F, and the other in NRTI mutations, for example, such as K101E, V106I, Y181C, G19OS were observed. And for integrase resistant mutations, from this patient sample, we could detect a major resistant mutation of INSTI E138K, and together with T88I, G118R, which confer resistance to dolutegravir and had intermediate resistance to bictegravir. And the rest of the patient were sensitive to PI. So we decided to start Bactrim for PCP prophylaxis because the CD4 level of this patient is going down below 200, and then we switched antiretroviral regimen to ACT plus TTC and boosted darunavir for genotypic resistance testing. And then we had a chance to repeat viral load testing again at 6 months after new ART, and the viral load testing revealed the level less than 40 copies per ml. The point of discussion of this case is we need to know the virologic failure of this patient, what is the cause or what are the causes of virologic failure, and what is the most appropriate regimen after TLD failure. So from genotypic resistance testing of these patients, the patient was on TLD, and the pattern of resistance testing show the patient has K65R that confer resistance to tenofovir, and has M84V, which confer resistance to emtricitabine and lamivudine, which is a classic mutation that we can find in TDF-FTC failure. However, in this case, genotypic resistance testing could detect Y115F, which is not expected to see. And when we look at the data, Y11F mutation is a mutation that confer resistance to abacavir in subtype B, and also in subtype CRF01AE. It can be detected in patients who fail D4T, DDI, ACT, TTC, and abacavir. So I think that the patient might have pre-treatment drug resistance. So point of discussion in this case, I think that the patient in this case, he has a failure because of, first, he has poor adherence to the regimen, and he might have a pre-treatment drug resistance before ART initiations. And from our guideline, we use genotypic resistance testing for selecting the next regimen. So there is a role of genotypic resistance testing for the second line regimen after TLD failure. However, we don't have the data of using TDF-FTC in this case because we are not sure that we can use these two drugs in the presence of K65R and M184V, like in Nadia trial that in the patient who fail NNRTI based regimen with K65R and M184V can still use TDF-FTC, but we don't have the data, so we decided to use ACT and TTC in this case. I think this is the end of my slide. Thank you very much.
Thanks so much, Opass. That was a really very thought-provoking case. I'm sure there's going to be a lot to talk about when we get to the Q&A. Let me go straight ahead now and introduce our next speaker, Dr. Jeremy Nell from the Wits Infectious Disease Research Institute in Johannesburg. Dr. Nhan is the head of infectious diseases at the Helen Joseph Hospital and the University of Witwatersrand in Johannesburg. He's the past president of the Infectious Disease Society of South Africa and an active member of the South African HIV Clinician Society, who has published widely on HIV and other areas in infectious diseases. So Dr. Nhan, please go right ahead.
Thank you so much for the, excuse me, for the warm introduction and for the excellent pronunciation of the University of Witwatersrand. So thank you. I'm going to go through the South African perspective on some of the very same issues which have been brought up. Our big challenges are that we have a public sector which treats about 80% of the population in South Africa, and a private sector that treats the remaining 20%. And there are separate guidelines, the Southern African HIV Clinician Society guidelines we're hosting today, obviously, and the National Department of Health, respectively. And we work very hard on making sure they align as far as possible, but there are greater resources for the private sector, and that does get taken advantage of in a good way in many cases. The great challenge we have, of course, with integrase resistance is that dolutegravir as part of a first-line regimen seems to behave very differently to dolutegravir as part of a second-line regimen. And there's additional issues about the cost of resistance testing that occurs when you are trying to factor that in. So the first-line regimen, we know this was a nice, someone in the background, but it was a nice paper published several years ago looking at first-line regimens, and this in 2020 could find only 5 cases ever of dolutegravir resistance as of when used as part of a first-line therapy. Many of them had fairly clear reasons for that, such as rifamycin that were administered concurrently. But that was really, this is over millions of patient years at that point. Whereas in second-line therapy, we know from multiple RCTs and some quasi-RCTs that the resistance rate is maybe somewhere between about 2 and 4% in a sort of 1 to 3 year period. And of course, there's some open questions about whether there might be a slightly better rate, in other words, a lower rate if you use tenofovir versus AZT from Nadia trial and other similar trials. And similarly, that's of course comes from clinical trials, and in a real world setting where adherence levels may be worse than in clinical trials, would we potentially see even higher rates at that sort of 2 year mark? The other aspect we have to deal with, obviously, is the cost of all of this, because the strategy is quite dependent on costs for obvious reasons, given the public funds that are utilized. Viral loads and drug levels, I've put the cost in South African rands in the middle column, but for those who are not from South Africa, the cost in US dollars, at least as of the 1st of October this month, on the right. And you can see there, the viral load and HIV drug levels are not that expensive. The resistance test is quite a lot more expensive. There's also relatively limited availability of that, although that can be scaled up if required. And so that you need to bear that in mind as well in terms of what the strategies are trying to achieve with the costs in mind. The scale of the problem is quite significant. As you can imagine, there's 6 million people on antiretroviral therapy in South Africa, but there's still about another 600,000 unsuppressed patients, as defined by a viral load of more than 1,000 copies per mil. That's according to 2023 estimates. This is, in essence, this is from the state sector guidelines rather than the Clinician Society guidelines from the private sector. But it's a busy thing, but I want to show you 3 components to it, really. This is patients who have virological failure while on a dolutegravir-based regimen. It's written there as TLD, as in tenofovir, lamivudine, dolutegravir, but in fact, it really would apply to any dolutegravir regimen in South Africa. The first thing is, and this is really trying to avoid doing resistance tests inappropriately, because they are the big driver of costs. So the first thing is, as we can imagine with almost every failure regimen in accordance with WHO and other guidelines, you need to fail twice with more than 1,000 copies. The second thing is that, at least as the guidelines written now, they really want you to have been on a dolutegravir regimen for more than 2 years. So if you've been less than 2 years, and that right-hand column there where the arrow has just popped up, you really just go back to the sort of cycle of saying, okay, let's go to routine monitoring and we'll check you in 6 months' time. In the end of this talk, this slide deck, I'm going to show you one potential change, because I think this is going to change soon, but this is what the guidelines are at the moment. Then if you're on TLD or dolutegravir regimen for at least 2 years, then they really ask you to look at adherence levels. And if adherence level looks more than about 80%, and you're on a second-line regimen, not a first-line regimen, then it's time for resistance test. Whereas if you're on a first-line regimen, for the reason I showed at the beginning, they still don't want you to have a resistance test. And if the adherence levels are low, they still don't want you to have a resistance test. The adherence levels, this is just a zoomed up version of some of it. The adherence levels on the bottom there, they give some measures, for example, pharmacy refills more than 80%, attendance at the clinic visits more than 80%, or interestingly, this detection of a drug in the patient's blood or urine, the antiretrovirals, in other words, some adherence marker. And this has been a challenging part of the guideline because, as you can imagine, the pharmacy refills, the data isn't always available to clinicians. Depending on where you work, it may not be. Attendance at clinic visits is useful, but again, people can come and still not take the tablets. And then the drug levels have not been widely available in South Africa. And I'll show you an example of where they are in a second. So that's the essence of where it is. It's quite really trying to avoid doing unnecessary resistance tests in a dolutegravir type area. And that's quite different from the past with different regimens. So I'll give you a case and then we'll talk to why this didn't work in a second, and I'll show you how we're considering changing it to make it work. This is a real case we had as part of a really nice study that's being led by Anne-Marie Wensing from Utrecht and Kim Stegen from South Africa and Wits University. And in this study, what's happening is in part of routine clinical care, they get patients who are non-suppressed on dolutegravir get a viral load, a viral load that's done. And if the viral load's up, they get a drug level done. And that gatekeeps further resistance testing. But this patient is in our clinic in routine care, not altering any other part of the care, was started on an efavirenz-based regimen, tenofovir, emtricitabine, efavirenz, from 2017 to 2020. Then in 2020, he's moved to a protease inhibitor-based regimen. That's AZT, 3TC, Eluvia, lopinavir, ritonavir. That was the guideline at the time because that was before dolutegravir was widely rolled out in South Africa. And then he developed some diarrhea, as often happens on lopinavir, ritonavir, and was moved across to AZT, 3TC, atazanavir because of that in 2021. And he was sent then into our clinic at that point, before then he'd be managed by a different hospital, sent to our clinic with virological failure. So a viral load of 739,000 copies, CD4 of 15 is a clinical failure too, and immunological failure, poor adherence previously, which drove most of this. Around this time, of course, South Africa was trying to switch everyone to dolutegravir-based regimen. In fact, from before this time, so he was lagging a little bit and moving across to there. And because of his previous regimens, we moved him then to TLD, so tenofovir, lamivudine, dolutegravir. And so this is a dolutegravir-based regimen. He'd never seen dolutegravir before in any integrase inhibitor, in fact, before. And we were following national guidelines which extrapolate from the Nadia trial, which I agree with the previous talk. It's not exactly the right scenario, but extrapolates that. In other words, we're quite happy recycling the tenofovir in this case. So what happened? He had also had no Darunavir resistance, by the way, at the time of switch. That's important. You have to do that viral genotype at this point before it all disappears under the wild type virus. These were the viral loads. That's a log scale there. That's around about 1 million. And he'd been hovering around that until this point here, March 2023. In March 2023, what should have happened, he's still unsuppressed on his new dolutegravir-based regimen, but he had been on it for less than 2 years. So in theory, we shouldn't have been doing really anything in terms of this other than just giving him his scheduled viral loads at the next visit. Fortunately, though, in the study, because he was a study period, we were able to deviate from that, and he got a blood test that was positive for dolutegravir and a resistance test then, which was reflexly done, which showed significant resistance. And again, I want to emphasize this, we're not in the study, would not have been detected because our guidelines would not suggest doing a resistance test at this point, at least currently. There was significant dolutegravir resistance there. That if you're interested, it was driven by this G118R mutation. But notice that had developed within 3 to 4 months of being on a dolutegravir-based regimen for the first time, and for the first time exposure to that entire class. And we're pretty confident of that because there was no other way other than at our hospital for getting an integrase inhibitor before he developed the resistance. So in our case, we could prioritize him for what's called a third-line committee application, but basically switch him to a different regimen. He got a Darunavir-based regimen, which is great because he was susceptible to that. He's actually done really well on that and done yeah, done really nicely. But the interesting points I think of this was firstly that resistance wasn't detected, it wasn't suspected by the clinicians because it was so early in his integrase exposure that the sort of teaching at the time was not to worry about that. He also didn't have any risk factors for developing it early, like rifamycin exposure or some other drug interactions. And he had a really poor history of prior adherence, and so that was just thought to be the case again. You know, if you've given him a new regimen, he should suppress. He didn't, probably just wasn't taking his medicines as he hadn't in the past. And the guideline, unfortunately, as I mentioned here, was wrong. Effectively, by this being part of the study, he happened to get the resistance test 16 months earlier, 4 months before, and he would have had this resistance test much later. So this is the last slide, really, which I just want to mention that in South Africa, there's a lot of debate now about moving towards a much less restrictive policy of dolutegravir resistance. One is that I think people are becoming more and more aware of these earlier failings, not at this 2-year mark, which was always a bit of a thumb suck, but the current recommendation is somewhere around 9 months. It would have still missed this guy, but that this guy's unusually early. That most people are later than that, but certainly well before 2 months. 2 years, they could develop resistance. So the current talk is about probably changing to 9 months if they make other criteria. Also, we know that this distinction between first-line dolutegravir and second-line dolutegravir is not easy to make, actually, because patients don't always admit to being on antiretroviral therapy in the past, and the clinic records aren't always good, especially if they move around. So we know people actually label people as first-line when they should be second-line. And then interestingly, there's some enthusiasm, although in a very early stage, of rolling out some drug-level testing as a gatekeeping mechanism, like was done in the study that I showed you, where there would be some drug level testing initially, and then only for those who have a high viral load, who have a positive drug test, they would then move on to resistance testing as a second line. And you can see from the costs I showed that might save, and it's predicted, at least on some early calculations, to save the country quite a lot of money, which is very important, obviously, in our environment. What form that will take is still being debated, and it's not yet committed to. There's very early discussions about drug level testing, but I think there's some enthusiasm given the difficulties of the cost of a resistance test, combined with this idea that people are failing dolutegravir, not in large numbers, but in enough numbers that we need to be doing resistance testing potentially well before 2 years, which is the current guidelines. So I'm going to leave it there. Thanks very much.
Well, thanks so much, Jeremy. That was a really very instructive case and provides lots of food for thought. Let's go ahead now with our final presentation before the Q&A. This is by Dr. Cordelia Katureebe and Dr. Francis Ssali from Uganda. Dr. Katureebe is a pediatrician and child health specialist who is the national coordinator for HIV care and treatment of the Uganda Ministry of Health and AIDS Control Program, with nearly 2 decades of experience with programs addressing HIV care. She leads a team of over 100 health workers and coordinates health system strengthening work across all regional referral hospitals and districts in the country. Dr. Ssali is the Deputy Executive Director of the Joint Clinical Research Center, the JCRC, in Kampala. He is also at Makerere University College of Health Sciences and has more than 3 decades of experience as a physician in internal medicine and hematology. He is a member of the Uganda HIV ART Technical Committee and the Uganda National HIV Drug Resistance Committee. He's been involved in ACTG trials and is also a member of the Global Gene Therapy Initiative. And so I believe Dr. Ssali is going to be doing the presentation, but then both will be available for the Q&A. So please, Dr. Ssali.
Thank you, Chair. Good evening, everyone. We decided to combine our talks, Dr. Cordelia and myself, because to fit in within the 10 minutes. So I'll give you some program data. My slides might move down slowly. Are you seeing any movement on the slides?
Not yet.
Try to unshare and then share again. Might be.
Okay. that all right?
We're seeing your title slide. Now we go.
Right, so-
There we go. Great.
Yeah.
Perfect.
Yes, so these are program data. Uganda, we have a centralized database for all our patients on antiretroviral treatment. Of the about estimated close to 1.5 plus million people living with HIV and AIDS, about 1.44 million are already on antiretroviral treatment. And this is our current data. And some of these patients, a small proportion, are on third line. We monitor patients in the national programs with viral loads, and all this data is centralized. And this the viral load uptakes in Uganda. So this is the way we monitor patients. We do viral loads every 6 months for children, and also we do monthly 1 yearly viral load for adults. If they are pregnant, we do them every 3 months, or if they are breastfeeding, we do them every 3 months. Now, our viral load suppression is, we consider it at, we have a cutoff at 200 copies. If they're above 200 copies, but less than 1,000, we consider that as low-level viremia, and we channel patients through some intensified adherence counseling, and then they continue the scheduled viral load testing until they achieve below 200 copies. If they progress to over 1,000 copies, then we again take them through further intensified adherence counseling, and we do another viral load. If it is above 1,000, then they have had treatment for at least 1 year of therapy, then we go ahead and do the drug test, the drug resistance testing. We have different platforms. We have dry blood spot testing for the HIV viral loads. This is what we used for quite some years, but we are transitioning away to plasma viral loads, and you can see that currently about 66% of our viral loads are based on plasma. Although the majority of our patients are suppressed, but among the ones who are not suppressed, this is the current data. Close to 10,000 individuals who have had 2 unsuppressed viral loads, and so this is the cascade. Those who are referred, samples referred. Normally, the patients receive their care from their clinics where they normally receive the treatment, but the samples are then moved to the labs where they can do drug resistance testing. All this is done through the central public health laboratory. So this is the cascade, and the success rate for sequencing is close to 40%, and a significant proportion of these have been reviewed. We review our cases regionally. The extent of review varies with region and clinics. This is data from our clinic, although actually it is from the centralized data. We have data on all the ART clinics in the central database. So you can track the patients by the clinic, and also communicate to them even by the clinician who sees them and or refers them. So this is the turnaround time for the drug resistance. Currently, it is under 3 weeks. It was a bit higher before, but the labs have done quite a lot to improve that. However, there are still some delays sometimes in referring patients from the clinics for drug resistance. Now, this is data summarizes the current, this is real-time data on all our patients in the country. So you can say it is accurate to about 95%, since that is about the level of viral load coverage. And you can see that dolutegravir, intermediate to high-level resistance, we among the patients who have 2 unsuppressed viral loads is about to 20% currently. If this is on your right, this is the trend. We had it much lower by 2021 among patients who had unsuppressed viral loads, but then it went up, and so currently it is a little over 20%. The darunavir resistance is still relatively low, and you can see abacavir, zidovudine, tenofovir, and then this is the DTG resistance among patients who have viral non-suppression. This is a map of Uganda, and it shows you looking at the extent of DTG resistance among patients who have unsuppressed viral loads. And you can see that in some areas, actually, a significant number of those individuals, about more than a quarter, between 25 and 50%, have DTG resistance. If you look at TDF, again, you can see that there are some areas where between 25 and 50% of patients with unsuppressed viral loads have TDF resistance. I think in the drugs that we use more commonly in our program, these are the drugs to which we have less resistance. This is AZT, and this is abacavir. So abacavir has more wide resistance. And unfortunately, it is the drug that we're using mostly in our pediatric programs until maybe we get tough. So in our program, we started with for drug resistance. We normally summarize the cases. So we get the identifier, where the patient is attending the clinic, and the contact of the clinician, the body weight and any other issues, and also we document the viral loads and the treatment history, and then the drug mutations and the relevant social and medical history that might impact on our choice of either to switch or not to switch the patient, and then any barriers. What we found that many patients actually do need some adherence support, and we're trying to go in depth with the barriers to resistance, and then we document the regimen. However, currently we now have all these in a centralized database, and the cases are discussed regionally, and also if they are very difficult cases, then they are discussed at the national level. We have regional drug resistance committees based on at regional hospitals, and they support the clinics within their regions. And also we have a national one which supports all sites. So I will share with you a few cases. This is a case of a child born 2022, initiated on abacavir 3-TC DTG. But as you can see, this child, within 2 years of initiating therapy, the child has 2 unsuppressed viral loads above 1,000 copies, and also previously had 1 viral load, which was low-level viremia. A single has parent, the single mother who is unemployed. So when we did the DR testing for this child, we actually found no mutations. So this patient might represent a significant proportion of patients within our HIV program. Since we do not have access currently to the, say maybe drug level testing, this child, if we were to switch this child blindly, would go into more expensive medicines, and yet the large problem is perhaps non-adherence. So this child will take this child through the caregiver through ART information to improve their knowledge on HIV and understand the issues around non-adherence and the consequences. And then we follow up and see if the viral load remains unsuppressed, then we can go through further testing. But this child would stay on the same combination. Next case, this is young person born in 1998. And this is the ART history, started in 2009 on azacitidine and then progressed to second line with TDF3TC atazanavir, and then was moved to TDF3TC DTG in March 2022. These were the viral loads. Had some periods of suppression and also some periods of non-suppression. So this patient previously was adherent, but was complaining of difficulties in swallowing the medicines. This patient, when we did the drug resistance to the integrase, NNRTIs, and PIs, there were some mutations, I think, from the previous drug combinations, and had started getting INST mutations. But when you look at the penalty scores, we use the penalty scores to make our decisions. So the DTG was still fully suppressive in this patient, but the previous drugs like efavirenz and 3TC were quite impacted, and TDF is still all right in this patient. So in this patient, again, we would just we expect this patient to actually suppress because has two active agents within their combination, to which she's having an optimized background therapy of 3TC. So this patient would go through more intensified adherence support and to find out exactly what is stopping her from swallowing the medicine so that it can be addressed. So third case, this is again another young person and has previously started on abacavir 3TC efavirenz as an adolescent, and then moved to AZT 3TC DTG, and then to TDF 3TC DTG. And you can see this person has never achieved any viral suppression. She's a school-going youngster and taking her ART well. So when we did HIV drug resistance after those two unsuppressed viral loads, and you can see that she has quite accumulated a number of INST mutations. Patients on DTG, we actually quite often see the E138K is one of the common mutations that we are seeing. And sometimes we see the 148 or the 140. So here the penalty score for DTG is 120. When it is 60 and above, that is high level resistance. So this patient is really got high level resistance. And you can see even to the NNRTIs, the previous drugs she'd had, maybe a traveling, this is a relative, maybe intermediate, the beginning of intermediate resistance. And the NRTIs, you can see AZT is almost done, 3TC is done. There's still tenofovir is low level resistance. So in our guideline here in Uganda, when patients have failed a previous ART, we ensure that we give them at least 2 suppressive agents if we can get them, and then we can add optimized background therapy. So this patient had full response to the PIs. So we would boosted darunavir would be a good choice because that is one of the most durable PIs, and tenofovir, we can still recycle it in this patient. Unfortunately, we don't have a second suppressive agent, so sometimes we choose the best suppressive, and then we give optimized background therapy, and we often keep the 3TC in because it still impacts on the viral fitness. So this patient was switched to boosted darunavir, TDF, and 3TC, and we added some traveling because there was still some potential effects from it. So that's how we're managing our patients in Uganda. I would like to acknowledge my colleague, Dr. Cordelia, who provided me with all the program slides, and also the Center Public Health Laboratory, the UVRI, the JCRC labs, and also the committees of clinicians and adherence supporters in the DR committees and the third line committee, and Dr. Jane and Alison. Thank you very much.
Well, thank you so much, Dr. Ssali and Dr. Katureebe, and thanks to all of our presenters for some really challenging cases. I'd like to invite each of the presenters now to please go on camera, so turn on your videos so that we can see you, and we'll start the panel discussion now. We've had a tremendous response from our audience, lots of questions. So I'm going to try my best to cluster them as best I can. And if I've overlooked something or missing something, Elliot, please jump in and help with the moderating as well. The first group of questions I think that came up for nearly all the cases is that there really does seem to be a contrast in the way people are thinking about the results of resistance testing and the results of Ernest and Nadia, where we thought from the clinical trials that it doesn't matter if you have resistance to tenofovir and emtricitabine or tenofovir lamivudine. The response to second-line regimens with either dolutegravir or boosted protease inhibitors was just as good, regardless of NRTI resistance. And it's not clear if that's really the experience in practice, and that some of the decision-making that we saw here was based on resistance, essentially, despite the results of the trials. I invite all of the presenters to comment on that question.
Well, actually, in my case, I think that in people who fail TDF FTC in the presence of K65R plus M84, we can recycling TDF FTC or TDF lamivudine. But in my case, I wasn't sure because there's another mutation that exists, Y115F, which is not expected. So I think I'm not sure whether this one can contribute to resistance to the other NRTI like TDF or lamivudine. So I decided to stick with the resistant test. I cannot see why 115F. I may stick with Nadia try that I can use the recycling NRTI. I'm waiting for the other response from the other panelists.
Do others want to comment? Dr. Ssali?
Yes. Yeah, we saw the results of the Nadia, but you know, when you look at Nadia results at the end of 12 months on treatment, among those patients who are on TDF but with some baseline DR to TDF, there was about 3%, 3 to 4% drug resistance to DTG that happened. And given the large number of patients that we look after, you know, that is something of concern. So, I mean, if we had close to 100, maybe if we had 10,000 individuals who are non-suppressed, that would result in quite a significant number of DTG resistance in our program.
Yeah, that's a great point. I think in the case that Opass presented, there's the potential advantage of hypersusceptibility to zidovudine because of both the 65R and the 184V. But then that has to be counterbalanced by what's the likelihood of being able to maintain somebody on a zidovudine-based regimen long-term because of the well-known toxicities that drove us to abandon zidovudine in favor of tenofovir as first line. Other comments on that point, or I can go on to Jeremy, please.
Sure. Yeah. So I mean that is the right question. I mean I think the issue we sometimes have with people's sort of unwillingness to fully take it on board, which I understand, is this idea that most of these trials were first-line NNRTI, switches. So they were failing NNRTI, switched to a second-line therapy. And there's the question is, would you be able to extrapolate that from, say, a PI or from second into third line? I will say in South Africa, we've generally gone with just extrapolating in the sense that I don't think there's a good reason to assume it wouldn't cross, but I mean, it certainly would be much more reassuring if we had direct RCT data to answer that question. But in general, for our program, at least, we do advocate tenofovir. So we've basically, there's almost no one in South Africa on AZT anymore, because if there's a renal issue with tenofovir, it's usually a back over, and that's even bigger extrapolation, of course. But there's very few people on AZT anymore. And I guess we'll find out if that was the right gamble. But anyway, that's what we do. Thanks.
Great. I'm sorry, Elliot, go ahead.
Well, Jeremy, so I was actually going to ask you on the case, if that person had K65R, would the third line have still used a tenofovir-based regimen? But I think you just answered the question.
Yeah, we would have. Yeah.
And I do think, what is the downside of using tenofovir rather than AZT in that setting is maybe you're going to get darunavir resistance at some point, but it's probably not going to happen, right away. Whereas there could be an upside in terms of adherence. That is always a problem with the AZT regimen. So I think the idea that Professor Ssali was talking about is this notion of two active drugs that you mentioned in your presentation. And that is a paradigm that we've operated under for many, many years. I think Nadia has, I don't know if it's put it on its head, it's tilted it, And so I think we need more data. Thanks.
There were also quite a few questions about whether for those patients who ended up on a boosted protease inhibitor regimen, whether the regimen was administered once daily or twice daily. So I guess the first part of that question really had to do was for Dr. Lee and about why boosted lopinavir as opposed to an alternative regimen. I gather the issue is access to other boosted protease inhibitors in Vietnam. So maybe if you want to start answering that part of it, and then we can have others chime in about once or twice daily regimens.
Okay, thank you for your question. So because it is related to drug supply, so we know that the patients have to encounter burden of abuse. Right now, it's very hard for most of the patients to have good access to darunavir in the country. So besides that, we also have the patients have to encounter a lot of side effects to lopinavir, ritonavir, that it is the interim in Vietnam right now. Besides that, it's very hard for us to have the access to atazanavir, ritonavir, or abacavir. So that is the reason why we have to choose zidovudine. Until we know that when the patient appears some symptoms, we think of anemia related to zidovudine. According to one study in my hospital, about 18% of patients have to stop zidovudine after 8 weeks of using that drug. So right now we have to follow up closely to this patient to change another regimen. And according to our guidelines, we have to consider NRTI recycling. Yeah.
Would somebody like to comment about once or twice daily dosing of boosted darunavir?
Yeah, in Thailand we have boosted darunavir, boosted lopinavir, and boosted atazanavir, but we prioritize boosted darunavir for our preferred PI because high genetic barrier and once daily regimen. But we sometimes use twice daily in the case with prior PI failure. For example, some people who has exposed to lopinavir or atazanavir and they have resistant mutation to lopinavir and atazanavir, and if they have one darunavir resistant mutation, we're going to use twice daily boosted darunavir.
Yeah, very, very similar in South Africa. So if it's based just on the darunavir resistance. So if no darunavir mutations, then 800, 100 once a day. Otherwise, 600, 100 twice a day for those with some significant darunavir resistance already. Yeah, same idea.
We haven't yet got access to QD darunavir in our program in Uganda, but I think we will adopt a similar approach like what the South Africans are doing. Where there is, even if they have PI mutations, but they are not darunavir based, we can still use it as QD.
Thank you. There were several. I'm sorry, Elliot.
Oh. No, I'm sorry. I wanted to circle back to Dr. Lee for a second, just because I think the other thing that the Vietnam presentation might have in common with some other countries that are viewing this webinar is the lack of access to routine resistance testing. And I'm wondering whether, or as in the case of South Africa, limited access to resistance testing, given the algorithm. I do wonder whether there's, for maybe South Africa and for Vietnam, of course, whether there's been some cost-effective analysis to look at whether the cost of introducing routine drug resistance testing to a country like Vietnam, or even more extensive drug resistance testing in a country like South Africa, might be, cost-effective compared to the empiric switch to lopinavir-based regimens that we heard described in Vietnam for a patient who was just unable to suppress on DTG, given that, at least from the Uganda data, we're seeing that as many as 4 and 5 or higher of people who, we think might be eligible for a switch to PI in a country like Vietnam, because of the Uganda information, are not going to be switched to a PI.
On that point, there were several questions about the cost of resistance testing, and just make an observation that there's a certain irony that in a country like the United States, where drug prices are so much higher, the cost of resistance testing is trivial compared to the cost of the regimens, whereas in countries that have access pricing, it's exactly the other way around, because we haven't done as good a job of being able to drive down the cost of complex laboratory testing like drug resistance testing as compared to the fairly effective efforts at reducing the cost of access to drugs. Jeremy, there was a question about why two standards of care or two guidelines in South Africa.
Sure. So it's really just a reflection of the country. It's a very socioeconomically disparate country, and so there is this parallel health system which covers 20% of the country and sort of who pay out their pocket for their healthcare, or with some sort of health insurance that they pay into, and then the other 80% which is covered, for the state sector. So it's a reality of the country, and so the guidelines sort of followed that fracture. We were very careful to try and align them as much as possible, but also where there is scope for some greater sort of, where there are more resources available in the private sector to not completely turn our back on that too, and try and harness them in a sensible way. So the guidelines are necessary because that's the way the country runs. It would be nice to have one system. We try and align them as much as possible, but we don't want, for example, those who do have more resources and are able to do slightly more intensive, say, monitoring or early access to resistance test to not have guidance around that. So we're trying it's an awkward dance though. It doesn't always work. And we're very conscious. Of course, people move between the two sectors too. If they, for example, if they become unemployed, for example, they may move to the state sector from the private sector. So that's also a strong reason to try and align wherever possible.
Sorry, I accidentally muted myself. One of the really interesting aspects of the case you presented was the detection of dolutegravir in blood, and I might initially have thought that the person was non-adherent because of the very high virus load. Could you say a bit, and happy to have others chime in as well, about what do we learn from drug level monitoring or testing for presence of drugs, and how does that inform the use of resistance testing?
Yes, I think it's still to be discovered exactly how this works, and it probably will be quite context specific because it depends on the relative costs of the various parts of the arms. So I mean, in answer a little bit to your question, Elliot, about the cost effectiveness, in South Africa we don't switch away from dolutegravir unless there's a resistance test that shows resistance. But at the current guidelines, which, like I said, I think are inadequate for detecting it earlier enough, you'd only get that resistance test potentially 2 years down the line. And so the cost effectiveness of doing resistance tests earlier in a setting where you're not doing them otherwise, obviously it's very hard to swing that. But what we need to think in the South African context is some better way of gatekeeping, not saying we probably can't afford to do resistance testing cost effectively for everyone on a dolutegravir regimen who has too high viral loads. But we also can't afford to do what we're doing now, which is wait 2 years. So that kind of ties back to your question, Dan, about the drug level testing, and that's one obviously way of doing it. As you know, there's tenofovir urine levels, there's serum drug level testing. This particular study was a sort of a test of a reflex test. So the lab itself would, on detection of a viral load, if they'd been on dolutegravir for more than 3 months, automatically do the rest of the testing, which is very attractive in terms of a sort of ease of programmaticness. It obviously would detect patients who would want to try and find earlier. Of course, the question is, what's the sort of positive and negative predictive value of that? So that we hope the leaders of that particular study will hopefully present it at CROI as an abstract, but we'll wait and see. But there's a lot of unknowns, I think, at the moment, and we're all quite anxiously looking at what the right stratification is in terms of cost effectiveness of doing that. I mean, clearly it would be good if resistance testing were $5, we would be doing it for everyone at the drop of a hat, and we wouldn't have this problem. But because it's not, we can't really afford to do a sort of first world or high income setting strategy of early access to resistance tests. So we have to gatekeep it. And we thought we could gatekeep with time, but that's not proven accurate enough. So our ears are open, and we're very interested to hear what others think as well.
Great. And then maybe a question for Francis. I noticed in your survey work that you found striking prevalence of abacavir resistance. I wonder how much of that was due solely to the presence of 184V, which might be partial but not really complete abacavir resistance, as opposed to mutations like 65R, 74V, or the 115 mutation. I'm sorry, you're muted.
Oh yeah, abacavir is the key NRTI that we use in our pediatric population, and we saw some skewedness in the virologic suppression. The pediatric patients generally had lower viral suppression, I think because of all kinds of reasons, perhaps sometimes not the best choice of medicines. But I think I'll ask Cordelia to make a comment. In part, it may be because of the 3TC mutation. That's why abacavir is quite widely affected. And as you saw, the resistance was not necessarily the very high level resistance. Yeah. So in part, I think it might be due to the high prevalence of the M184V. But Cordelia, you on the line, you can please make a comment. Cordelia?
Yes, Dr. Francis, just clarify that again. The issue around about abacavir.
Yeah, abacavir being more widely, there was much wider resistance to abacavir. Yeah.
Yes, I think the direct question, yes, a lot of the children, so almost about 470 children that are currently on, that have drug resistance and have been put on actually third line. That's around the figure that we look at. And we can confidently say that by the time that the switches are made, we already have a very big proportion. I probably won't say it off head, but the 180, the mutation that is seen in abacavir is the one that really causes the switch that we make. But I think it's data we can look at and analyze deeply and be able to get the exact information.
Great. Well, we are out of time. It's 1/2 the hour. I have another meeting I need to run to, but I want to first of all thank once again our terrific presenters for those really informative cases and all the background information. Thank our listeners for all your questions. I'm so sorry we didn't get to answer more of the questions. However, if you come to the HIV drug resistance workshop, April 9th through 11th, 2025 in Cape Town, you'll have the opportunity to get all of your questions asked either during the sessions or in the important conversations that happen during the poster sessions and in the hallways, and be able to interact directly with all of our speakers. So please register for the meeting, and we look forward to seeing you in Cape Town. I'd like to thank the South African HIV Clinical Society for helping to organize today's webinar, and also the International Antiviral Society USA for helping to publicize this webinar. Thank Elliot and for his support and guidance as well. And it's been a real pleasure. So thank you all, and have a good day.
Thanks, everyone.
Thank you, Dan. Nice meeting you.
Thank you.
Goodbye.
You are awesome.
All right, that was great. Thank you.